history in the making. Um, I would like to start off with, I was going through, as any one of you would go through different phases of life, I was going through different phases of my life, and I used to question my existence and what I'm supposed to do. जब मैं presentation बना रहा था तो मैंने कहा यार कि is there a deeper meaning to point of care ultrasound and us? And is there deeper meaning to echo and us? And I found this nice verse from the Holy Quran. Oh God, lost your connection. I think dongle आपके सामने ले आया. There is some problem with the internet. The internet सही है इसका? Disconnected, right? Okay, so it's back on, I think. That should be coming back on again. Sorry about that. So I was going to, let us start on first. So there's a problem with the internet, I think. Yeah, that's fine.
Dr. Azim's phone se connected.
Yes, that's fine, thank you. So I was going through the verses from the Holy Quran, and I tried to find out, was there an existence of echo well before Islam or well before any other religions? And this is what the Quran says. And surely we bestowed upon David grace from us. O mountains, echo with him my praises, and you birds too. The concept of echoing came from there, and there were a few other verses in the Quran which says that the existence of heavens speaking to us is via echo and via sound, and there are a few verses on that as well. So I was quite fascinated by the fact that these things actually existed then as well. So start off with today's level 1 ultrasound course. First of all, very brief introduction of who I am. These are the brief institutions that I've been working with, either as a registrar, as an SHO, as a trainee. At the moment, I'm working with developing a course in Wales. It's the first course in National Imaging Academy Wales. That's especially for radiologists, but I'm trying to intervene it and starting as EM trainees to start training. And we had our first course done earlier on a month ago. And currently I'm working in University Hospital Wales. Dr. Ashfaq is my mentor, my teacher, my inspirer. Without him, probably I wouldn't be here, because you need people who would hold your finger and you hold their hands at the end of the day. So I'm a minnow in front of him, but as they say, if you inspire to become someone, eventually you will reach at least their feet someday. So hopefully I will be able to touch his foot someday. So our goals are to have 1,000 level 1 ultrasound trained doctors in the next 10 years, hopefully in the next 5. A level 2 ultrasound focus course biannually we are planning to conduct here. Yearly, I would like to, this is my dream, to give a 50 ultrasound guided regional anesthesia procedures and nerve block course that I'm planning to intend with Ashfaq Bhai. And to produce leaders in emergency medicine ultrasound and focus. So in the next 2 to 3 years, I'm expecting regional leaders from LGEM, and I have spotted a few people straight away, which I'm not going to mention names at the moment, but who I see the potential of being instructors as regional leads in ultrasound. So this is our aim. So my aim is to increase my knowledge through my teachers and to teach my students enough that someday they will teach me. That's my dream, so that my knowledge will increase. Level 1 ultrasound course. It consists of EFAST, ELS, vascular access, Facial iliac block, that's the minimum that you should know. We'll learn what these things are. We're not going to become experts in that, but we'll know exactly what it is. So next time you see a patient, you know these things can be implemented and you can save a life. Ultrasound guided regional anesthesia, pen block, facial iliac block. These are facial iliac block is very basic, but even then it requires a lot of training, a lot of hard work into it to become an expert in that. It is an art. It's not something that you can ratify and then you can just go ahead and do it. Every single step from turning on the machine to guiding the probe, every single step has got a logic, a science behind it. And if you learn it the right way, you'll become the right person. If you try to digest it all in one day and think that after today you're going to become an expert, it's never going to happen. Okay? So EFAST is extensive focus assessment using sonography in trauma. What does it comprise? Basically, mostly it's for abdominal traumas. It's a rapid and repeatable tool that we can use. It does not require a patient to be stable, so you can basically do it at the bedside and in an unstable patient's indication. If the patient is stable, take him to CT. If the patient is unstable, you put a focus on. You put a jelly on the belly and find out whether it's bleeding or not. It's not recommended in children till now, but there is good evidence that in the future it's going to be used in children as well. So the objectives, to detect free fluid in the abdominal cavity, in the pericardium, in the pleural cavity. These are simple basic ABCs of EM ultrasound. So accuracy, most clinicians will detect greater than 60 to 50 ml of free fluid. The amount of trauma that we have got, the kind of traumas that we have got in Pakistan, most likely each and every one of you can pick up this. To reach an expertise and to detect up to 225 ml, probably you need Ashfaq Sarathia to do that. Okay? So detect a small amount of fluids, the more you do it, the more you become an expert. I'm not saying you can't do it, but you need a lot of experience and practice to do it. So the equipment that we're going to use for this is a low frequency probe. The depth is set to 15 centimeters. TGC should be greater than, the gain should be more appropriate, and we should acquire and label the image. The views that we have to do, at least 5 views, and they may increase over the next 10 years, by the way. 5 views, right upper quadrant, left upper quadrant, the pelvic view, pericardial view, and the pleura. Let's start with the right hypochondrium. So the placement of the probe is just anterior to the mid-axillary line, or probably just posterior, depends upon where you see the junction of the liver and the kidney. We have to identify basically the Morrison's bulge. Angulation, I'm going to teach you how to hold the probe. Ashfaq is going to teach you the accuracies and the details. It's just a go-through of what we're expecting during the day. And we have to rotate the probe a bit, a few degrees, to find the right image. What you're going to see, and while you hold the probe, is this. Give me a sec. So this is what you're planning to see. See this area. This is where we need to see. This is the most dependent part of the body. This is the place where most likely a patient is lying down, is the area we'll see the free fluid accumulating. And this is the area we're targeting with our ultrasound beams. Ultrasound beams are just like light beams. If you see a wave of light going through, that's where exactly you need to shine the light on. Okay? So Morrison's bulge is the area we're looking for free fluid. So this is where you're going to put the probe. This is the beam of light. This is the area you're targeting. Between the kidney and the liver, this is the area we need to find the free fluid in. Is that clear? Try not to write any notes. You can find everything on the internet. ये 20 साल पुराना वाला दौर नहीं है कि आप आएंगे सर आप मुझे सिखा दें. I think you guys should be teaching me after that. Okay, everything is available on the internet. The only thing you have to find out whether you're reading the right material, whether your intellect for reading literature is good enough. Okay, right or wrong, don't know material. Like, you have to find the right material. Okay, this is the area you are trying to identify. Okay, and what you're going to see. What's the stone anatomy that you're going to see? So this is the area, liver, kidney. The area in between is where you're supposed to find free fluid. Okay, it can be blood, it can be free fluid, it can be anything else. Whatever it is, it's not normal. Okay, so see the images over here, how you rotate the probe up and down, and this is what you're going to see. Simple. कोई problem तो नहीं है इसमें? Next, this is the pathology. Can you see the free fluid? Jet black. This is what you're aiming at. See the difference between normal and abnormal? Good. So once you see this, you know that this patient most likely needed a laparotomy. Okay? In the context of trauma, of course. Left upper quadrant view. Similar placement, slightly difficult, slightly higher on the left side as compared to the right side. It's slightly more posterior. Okay? And the images is quite identical. Left upper quadrant view. This is where you put the probe. This is where the line of beam is. Sound. And see the angulation, the acute angle. It's literally touching, your probe should almost be touching the bedside. Okay? This is what you're going to see. Very similar to the right hypochondrium. Kidney, spleen, left upper quadrant view. This is the area you have to identify. And there's another area above the spleen. See the green line coming over here? That's also a prime target. You can't, if you don't see free fluid here, you can't say that there is no free fluid unless you identify this spot as well. So you have to reach above the spleen, because the literature, the latest literature now shows that this is the area we have to target, because unlike liver, spleen is quite mobile, and you can accumulate fluid above the spleen as well. Okay? So as you can see, some free fluid here. What is this? What's this? What's this? Diaphragm. This is the spleen. This is the kidney. Okay. There is fluid above that. Okay. Pelvic views. It should be sagittal and horizontal. We need to identify two views. It's much lower than your thoughts might perceive. It's literally just above the pubic symphysis where you have to put the probe on. Quite often people put the probe just below the umbilicus and miss the whole story. Okay? And it's the pouch of Douglas, rectovesical pouch, and the rectovaginal pouch that we are looking at. In all the fast scans that you're doing, almost all of them, with the exception of few, the pointer should always be face towards patient right or towards the patient's head. Is that clear? Most of them. Not all of them, most of them. And this is what you're going to see. When you put the probe on, this is what you're going to see. You scan the bladder, and the next image I'll show you the sternal anatomy. Is it male or female?
It's female. Female.
Dr. Azim is always right. He does a lot of gynae surgeries along with the general surgeons, yeah? Okay. Basically what you're trying to identify, excuse me. This is the bladder, you can't miss that. That's one thing that you can't miss. It's the easiest thing to identify in the body if it is filled. If it's not filled, it's not going to be this big. Uterus, you have to identify fluid somewhere around here and here. Okay? Anywhere in between the organs that you can identify, you have to identify the fluids. Okay? Where do you think is the rectum then? It's empty, flattened. It's not appearing. This is transverse view. Okay. Again, see the free fluid? And remember, you're not sonologists, you're ED physicians. And for you, you have to correlate the picture with the scan. For you, it's not important whether this person has got one ovary, two ovary, whether it's a male or female. But what you do need to know is when you see a free fluid there, you know that's not bladder, that's bladder. Okay? Once you identify free fluid, you know that patient is not a very happy patient. Next is the pelvic sagittal views. See the propositioning? The pointer is directed towards the patient's head. This is the pointer, little teeny bits out there. And you have to fan your probe across. Okay? So you see some free fluid here. That's very obvious, isn't it? Okay? So you know that that internal organ has been damaged, there is some bleeding. Once you identify that, you don't need a CT scan. If the patient is unstable, shift him to theater. Okay? In this case, the mortality rate for surgeons is going to definitely decrease as well. Then start liking you as well. Pericardial views. So these pericardial views are dedicated for fast scans only. These are different from echo views that we do. Okay? So the indications for fast scans for ED physician is very different from a cardiologist, from a sonologist, okay, and from a radiologist. So what you need to do is find the pericardial space, look at the ventricle size, and the ventricle's contractility, little things. And as you go along and do more and more echoes, you'll find that, oh, I can identify an abnormality because you will see enough normal ones. Once you see the abnormal one, you'll know what's wrong. So the subxiphoid view, this is a very important view for an ED physician. Reason being, because most people don't know how to hold the probe. They dig it straight into the tummy. Well, actually, you don't need to. You need to make it flat, almost parallel to the stomach. Okay? The abdomen should be almost parallel to the abdomen. You don't need to dig it straight down. Okay? And once you dig it enough, just parallel to the stomach, you're not going to cause much pain to the patient, and you're going to have really good views for echoes. Okay? And what will you see then? Subxiphoid view. Liver is your friend. What side is this? Right side or the left side of the heart? Who says right? Raise your hands. Okay, so the rest of the says is left side? That's what I'm assuming. So that's the right side of the heart. That's the left side of the heart. In between is the pericardium, and above that is the liver. Pericardium, and this is the liver. This is the right side and the left side. If you can identify the liver is on the right side. The rest of the heart is also on the right side. This is the right side that you identify. It's common sense. There's no rocket science to it. This is right ventricle. This is right atrium. Then it's going to be the left ventricle and the left atrium. Okay, this is subxiphoid view. And what are you looking for there? What do you think? Is this normal or abnormal? Who says normal? Raise your hands. Okay, and who says abnormal? Raise your hands. And the rest are just not interested. Just kidding. So this is the subxiphoid view. This is a free fluid there. There's a pericardial effusion. It may be traumatic, it may be atraumatic, it may be acute, it may not be acute. That's not relevant. What is relevant is that this does not look like a happy heart. Okay? I need to do something about it fast. Next image. This is a long axis parasternal view. The pointer is facing patients towards patient's right shoulder, and these are the complex images that you will see. It looks difficult, but it's probably one of the easiest views to obtain. Okay, it does quite a lot. What do you think this is? Right ventricle. What do you think this is? Sorry? Left ventricle. What do you think this is? Excellent. What do you think this is? What's this moving thing is? Excellent. You guys know. Brilliant. Excellent. And what do you think this is?
Pericardium.
Yes. Is this does this look normal or abnormal?
Abnormal.
Why do you say it's abnormal?
A fluid.
Anechoic area.
Whereabouts? This?
At the bottom.
At the bottom?
Yeah.
This one?
Yes.
What do you think this is? What do you think this is?
This may be vena cava.
So this is descending thoracic aorta. Okay. Anything above the aorta or the pericardium is pericardial fluid. Anything below the aorta is fluid in the lungs. So you have to differentiate that. I mean, we can go in details and we can go on and on for hours on a single slide. But the major chunk is there fluid effusion in their pericardium? No. Is there fluid effusion at home pericardium? No. The chambers, right ventricle, aortic outlet, and the left atrium should all be, the ratio should be 1:1:1, generally. Okay? If that's okay, most likely the heart is okay. Obviously, you find some other pathologies if you want to, but this is, as an ED physician, this is the basics that you should know. Okay? So EFAST, the extended fast, recently included. What we're looking at is the pleural space for free fluid and pleural movement. Absence of pleural movement indicates most likely, but not confirmed, pneumothorax. So there are other conditions in which the pleura might not move. Okay? So how do you see the lung views? The pointer is towards the patient's head, and you have to identify the ribs. You have to go in between the area, target the area between the ribs, and this is what you can see. This is the glistering membrane, which is the pleura, and this is the reverberation or reflection of artifact of the rest of the pleura. Okay? And what you need to look at, the next slide will show. So you can identify, this is the chest wall, this is the lung sliding over here, these are the ribs, and see this blistering, shimmering movement? This is normal lungs. Okay? If there's no movement, and this is static, like this, that means there's most likely pneumothorax. We'll come into the details once we are with the probes. Why is most likely pneumothorax, not confirmed pneumothorax? There are other conditions in which the pleura might not move. Okay? Any questions so far?
How do you definitively align the patient? How do you know whether it's the right side or the left side definitively? What is the basic technique?
Okay. So the thing is common sense. Okay. You touch the probe, you identify on the screen which side is which, and then you put the probe on.
And that's how you identify.
That's how you identify. Yeah. Because in the rush of time, when you got a dozen people working around you, and a trauma team leader is instructing you to do the echo, and you got a window of less than 10 seconds during CPR to identify the area, you should know your shit. Otherwise, you know your shit.
You're in trouble. Yeah.
Okay. There are other ways of identifying it as well. That's why we do the hands-on as well. Okay. But the important thing is in cardiac, when you're doing the cardiac echo with the cardiac probe, everything is opposite. The pointer is towards the opposite side. Okay. In that you can't touch and see which side is which. Okay. The important thing is to know your anatomy. So in whatever position you put the probe on, you close your eyes, you put the probe on, you know which side is right and which side is left when you look at the sonoanatomy. If you don't know your anatomy, no matter how much anybody's going to tell you which side is which, you're not going to identify the structures. Okay? So knowing the side is not as important as knowing the anatomy. Okay? And knowing the anatomy is not that important as compared to knowing what to look for.
Yeah.
If you're looking for pericardial effusion, you will find it if you're looking for it. Okay? The eyes don't see what the mind don't.
Yeah.
Okay? Any questions so far? In? Because the space, the evidence does not support that there is enough space between the liver and the kidneys. There are other evidence, I'm afraid I haven't looked up into it because it's not applicable in children. But what I've heard is in London, Bromley, they're starting level 1 ultrasound course for children as well. So I think the evidence is coming up now that can be used in children, but not as extensively as in adults. They are definitely using it to identify fractures in children. Okay, they are definitely using it to look at intracranial pressures. Okay, but other than that, I'm not aware of. Okay, I should be honest with you. But maybe a few years down the line, I might be doing one here. So don't pick me on that, because I said the evidence is coming up. These are my brief contact details. If somebody want to catch me professionally, this is where I exist. Okay, so go on to our next slide, next presentation. Any questions so far? Yes.
Then obviously differentiate it is blood in the cavity or it's the only fluid.
So blood appears black, jet black,
Jet black.
and we are not supposed to identify whether it's blood or free fluid. We are not supposed to comment on that. Remember, we are ED physicians. For us, it's free fluid. It's never blood. Never say that it's blood, because you may be wrong. It may be pericardial effusion. It's not blood. Okay? It may be serous. It may be serous sanguis. Okay? So never ever, when you're working in the UK, say it's blood. We never say that. We always write and document it's free fluid. Because nobody will know, not at our level as ED physicians, whether it's blood or it's fluid, other fluids. Okay? It may be a ruptured bladder. You don't know. It's maybe urine. But how will you differentiate that? There are other settings of the machine for that, but we are not trained to do that, and we are not supposed to know that. Okay? So everything is going to be in the context of, oopsie, it's gone. Oh, God. So everything is going to be in the context of, I think we lost contact again. In the context of the clinical presentation. Oh boy, here we go again. Hold on a sec. Yeah, it's showing up, but it's not showing up on the system. I'll start screen sharing. Start screen sharing. Start screen sharing. Yeah, should be okay. Start screen sharing. It's coming up now, I think. Yeah, got it. Thank you. Got it, done. That's fine. So, next one is AAA. It's a quick 10 minutes presentation, nothing fancy, but it's very exciting. I think in the previous ones, the EFAS scan, if there are two things I really want you to pick up and not miss, is fluid in the right hypochondrium, okay? Fluid in the right side, between the liver and the kidney, okay? This you should not be missing after today's workshop. Number two is pneumothorax. If there's no lung sliding, you should know it's pneumothorax. Don't get an X-ray. That's not indicated in the pneumothorax, not anymore. Okay. If you're sending patient to the X-rays to check if it's pneumothorax, the patient's probably going to die when it's come back. Okay. So put the probe on, see the lung sliding. If there is no lung sliding, you know it's pneumothorax. Decompress it. Okay. Abdominal artery aneurysm. Has anyone seen a patient of abdominal artery aneurysm rupture? Anyone? Azim bhai? No?
They didn't land to the.
They died before.
They died before.
Okay, so today is your chance for changing that. Okay? Today is the chance where you'll probably save a life. So, objectives. So regarding the identification of AAA, we have to identify the probe position, we have to identify the proximal aorta, mid aorta, distal aorta, Then we have to look at the longitudinal view. We have to identify if there is a saccular artery aneurysm. We have to identify whether there is a leaking aneurysm, and whether we have to identify whether there is a dissecting aneurysm. Okay? Because once you tell a vascular surgeon that I've got this, he will ask you, बेटा बताओ कि ये leaking है नहीं है, dissecting है या नहीं है, secular aneurysm है या नहीं है, because he will have to prepare his theater according to that. Okay? So knowing your numbers, if it's greater than 3 centimeter, most likely it's abnormal. If it's greater than the lumbar vertebra, the size of the lumbar vertebra, okay, in comparison, it's most likely about 4 centimeter. Okay? If somebody's got hypertension and the size is more than 5 centimeters, it's ruptured unless proven otherwise. Okay? 3, 4, and 5. These are the magic numbers. So probe position. You're using a curvilinear probe. The pointer is either towards the right side or the left side. Simple. Sorry, right side or the patient's head. Okay? Okie dokie. So, what do you see? What is this? See, lumbar vertebra. This is the aorta, this is the IVC. If you press it too hard as a slim and tiny patient like me, you probably compress the inferior vena cava and only aorta will be visible. You're compressing the aorta and the vena cava against the lumbar vertebra. Okay? And that's what you're seeing over there. If you compress this area, it's going to appear like a pulsatile thing. And if you compress this area, it's going to disappear. That's IVC, that's aorta. Aorta is on the left side of the vertebra roughly, and IVC on the right side. So don't confuse between the two. Okay? So this is the proximal aorta. This is the celiac trunk. This is the right hepatic artery on the right side, and the splenic artery going on the left side. We call this the seagull sign. For a brief second, you will see it over here if the red spot doesn't appear. We try to identify the celiac trunk if we can today, but we're not always lucky. If there's gas in front on the stomach, the chances are you will not be able to see the images. Why? Because air is an enemy of ultrasound. That's why I put jelly on the tummy. So the sound waves transmit and reflect back. Okay? So this is the seagull sign and proximal aorta. This is how it's going to appear. This is the aorta. This is the IVC. This is what you're interested in the celiac trunk and the splenic artery and the hepatic artery. What's the importance of this landmark? Does anyone know? Basically, if you can identify this, this means that you're at the pinnacle, at the top of your aorta, where you have to scan as an ED physician. If you can't identify this spot, chances are you're missing a possible aneurysm at the top of the aorta, proximal end of the aorta. Is that clear? So this is the point where you should be seeing. So this is a mid-transverse, very simple one. You put the probe on, patient is screaming, make sure you give him enough analgesia, and make sure the patient is lying flat. This is what you're going to see. This is a false lesion. This is a bit of thrombus. This is the actual aorta. And it's massive. Once you see this, you can't miss it. You put the probe on, you see a AAA, you will know it. You just can't miss it. Okay? And that answers your question, Azim bhai. Why don't you see it? It's because you miss it. They die before they reach to you. But once identified, you can contact the vascular surgeons. We have definitely got a AAA. Come down to theaters, get sorted. Okay? The mortality rate is still very high. Okay? Yeah? What do you want to know? So this is the aorta. Anything above 3 centimeter is abnormal. So it's 7 centimeter. Now you will not miss it. Okay. This is the distal aorta. It is the transverse image where the probe pointer is still pointing towards the patient's right. And this is what you see. Can you see this dumbbell sign or the pendulum sign? One is converting into two. That's the splitting of the aorta into the iliacs, common iliacs. Okay? See, this will split into two. One, two. You're sliding the probe from up downwards. Okay? What is this then? Vertebra. That's the vertebra. The aorta is just anterior to the vertebra. Is that clear? Grasp what you can from today till I finish these boring lectures. And once we're with the machines, I will explain you and ask me questions then as well. Okay, regarding probe orientation, where to put the probe, how to put the probe, should we put it softly, should we put it hardly, should we put more force on it, should we slide it more, should we slide less, all these radical questions. So this is the longitudinal view, where the pointer is facing towards patient's head, and this is what you see. Can you see the aorta? See the hole then? So how does it differentiate aorta from say, IVC is you put the pulse wave Doppler and it will, power Doppler, it will say whoosh, whoosh, whoosh. It's this kind of sound. I'll try to show it with the machine over there. And the other thing you need to know is that the proximal end, the aorta, I'll show you if it goes on. I think something has gone wrong on the internet or something. I think the internet's not working. Naturally. So we're going to see. Yeah, it's working. It should be working. Let me restart it, sorry. Maybe it's not loaded on time, but don't do anything. Sorry about that. Yes. Any questions so far? Any questions? So it's not a difficult job to learn the art of level 1 ultrasound. It's just a bit time consuming, and it takes a few years before you become confident. At this moment, you're going to probably take about 20 minutes to find the right mitochondrium maximum. When you become senior, it's just going to take you 10 seconds. Chalgi, yes. So, what you see here is you have to identify, if you can, the superior mesenteric artery. Do you see the superior mesenteric artery here? Just anterior to the aorta. Aorta, superior mesenteric artery. It's coming from the aorta. The other identification mark for the aorta is, instead of going up proximally, the aorta goes posterior side towards the diaphragm. Okay, so that's the classic concave sign. It's going from above downwards. That's most likely aorta. Okay, the other thing to identify if there is a superior mesenteric artery that's coming from above. I'll try to show you everything, and you will be able to identify at least the transverse image of the aorta and the longitudinal image today. Easy peasy, no problem. Okay? Now this is a saccular aneurysm. Saccular aneurysm don't tend to go the whole length of the aorta. They may be present in the mid part of the aorta or the distal part of the aorta. And this is what you see. Crescent sign on top of the aorta. Okay? A part of the length of the aorta where it's present. Okay? Saccular. Yes. Internet is a bit poor, but hey ho, it's showing the saccular aneurysm. Is that clear? And this is the, which view is this? Transverse or longitudinal? Which one? Yes. Leaking aneurysm. Can anyone identify where the leak is? Where? Right side? Left side? This one or this one? This one. No, this one. This one. This is the calcified aorta, and this is the leak. This is the thrombus. This is blood in the normal aorta, where it would be. Okay? This is blood. This whole area is thrombus. This is blood, and there's a rupture or a leak, which is leaking outside the calcified area. Okay, boss? Understand? And in order to measure the length, or sorry, the diameter of the aorta, you have to identify the outer wall to the outer wall, not the inner wall to inner wall. Is that clear?
Is it the pseudo wall?
This is the pseudo wall. Yes, you have to go outer wall, outer border to outer wall. Because sometimes the calcification is this thick. See how thick the calcification is appearing here? You have to include the calcification as part of the diameter. Otherwise, you will underestimate the circumference. Dissecting aneurysm. See this flap? Boundary within a boundary. Okay? I call it the illegal state within a state. Okay? So there's another boundary inside. And this is dissecting flap of an aneurysm. And you'll be surprised to see these dissecting flaps may reach all the way from the heart all the way to the common iliacs and femorals. Okay? That's why it's important to trace all the way. Sometimes patients will present with ischemic limb. If it's bilateral ischemic limb, the chances of aortic dissection and aortic obstruction is quite high. If you're able to see a clot, a thrombus, which will appear like a gray structure with a black fluid, which is most likely blood, that means there's a thrombus in the aorta. Is that clear?
Yes.
Any questions? No questions? No? Question is a sign of intellect. Ask me. Which one? Which one? What kind of pizza that you want? Any pizza. Okay. Leaking? This is leaking. Oh, sorry. It's not appearing. It's held off. Saying वहाँ पे नहीं चल रही है, यहाँ पे तो चल रही है. Is this connected to the internet? अब चला शुरू है. Hold on a sec. Leaking. See the leak? Anything outside the leak? You got a pipe, it's leaking, it's going to leak outside. So the gray is the thrombus, black is fluid or blood. This is black as compared to this. This is thrombus, clotted blood. Okay? Do you understand? No? No? Yes? No? No? इधर आइए, क्या नहीं समझ आ रहा? This one? This is black. You don't call it gray. Gray is this. इससे भी ज़्यादा color blind हो गए आप. Any other questions? Good. We'll take a 5 minutes break. Well, I'll take a 5 minute break and I'll be back. Okay? पानी पीना है
दबा दो
देखा तो क्या होगा उसमें अभी पोचा तो रास्ता हो गया लाहौर में हो गया ना जो एक बंदा देख रहा है उसे देख ले
3 लाइट्स आ गए